Welcome to episode 1 of the Annie's Centre podcast. My name is Justin Kingdon.
And I'm Dr. Anne Chalfont. And in this episode, we'll be discussing understanding anxiety, some initial tips for parents on how to build their children's confidence.
And I will share with you one of our family favourite recipes in the section Kids in the Kitchen.
One mother, one mission, to create a world where families thrive. Dr. Anne Chalfont, internationally acclaimed clinical psychologist, family therapist, author and mother of 4 children, brings you powerful and practical parenting techniques from her clinical and personal experience. Ladies and gentlemen, the doctor is in the house.
Okay, before we begin, the Annie's Centre podcast is supporting the Buy from the Bush campaign here in Australia by promoting Australian businesses. So, do you know what your friends and family are looking for, Anne? They are looking for fantastic meat. So, you need to head on over to ourcow.com.au and buy paddock to plate beef boxes direct from the farmer. So who are the farmers? Bianca and David, and they offer one-off bulk beef packages and ongoing subscription boxes so you never run out of meat. The beef is hand-cut by master butchers in the heartland of Australia's premier state, New South Wales, and sent fresh to you. We have purchased a beef box from Our Cow, and we can tell you that the process is seamless. You get text messages to track your delivery. The meat is fresh and delicious and cold, and it all comes conveniently vacuum sealed, so you can chuck the steaks on the barbie that night or freeze it for when you need it. So don't panic, you are getting a bulk beef box. It's not like you're bringing home the meat tray. Because it's vacuum sealed, it takes up little room in your fridge or freezer. So know that your hard-earned dollars are going direct into the hands of our hardest working Australians. And buy from the bush. That website again is www.ourcow.com.au, ourcow.com.au. Go visit the site, check that they deliver to your area, buy a beef box, and you too can support Australian farmers doing what they do best, which is make the greatest produce in the world. Our Cow. Buy better meat. Now, on with the show.
All right, well, welcome to the first show, and it's jam-packed with information for families. So we're going to begin with our first topic, our first ever episode of our first ever podcast, which is understanding anxiety. And since it is our first, we're probably feeling a little anxious ourselves, aren't we, Justin?
Yes, absolutely. But it's all natural, right?
Absolutely.
Okay, so, Anne, anxiety seems to be on the rise in Australia. According to the Australian Bureau of Statistics, almost 4.8 million Australians, or 1 in 5, had a mental or behavioural condition in 2017 to 18, up from 4 million in 2014 to 15. Anxiety-related conditions have increased, and they are the most frequently reported mental health condition in Australia for the last 3 years. So that's some fairly big numbers and quite significant.
Absolutely.
Okay, clearly. So before we dive into something as big and as serious as this, can you define anxiety?
Sure. So anxiety is really just a feeling of, a natural feeling that we all experience of being nervous or worried or tense in the face of a threat or a perceived threat or stress or some form of danger. So it's a natural response that we have in those situations.
So we all have a bit of anxiety.
We will all at some point experience anxiety. We all are capable, absolutely, of experiencing anxiety. The issue is the difference between what we call healthy anxiety and unhealthy anxiety. We're all going to experience healthy anxiety at some point in our life, and probably relatively regularly, whenever we might put ourselves under pressure. For example, recording our first podcast,
Right.
Or giving a speech, at school if we're talking about kids and teenagers, or meeting someone for the first time in a group situation. Those sorts of situations. They're all situations where someone would experience a normal dose or a healthy dose of anxiety or trepidation.
Right, okay. So it seems as though then that there is healthy anxiety,
Yes.
which is just part of if you're active in the world and you're participating in the world, and
Yes.
you're not a total couch potato, you're going to have some level of anxiety. Yes. Okay. But then there has to be some movement from being healthy to an unhealthy level of anxiety, to the point which you as a clinician would classify that as a disorder. So based on the fact that you've got a specialisation in anxiety,
Yes.
can you help me understand, when does it move from being a normal part of your life and something that you have under stress or under certain occasions which you would expect it to occur, to it then being classified as a disorder in you, and so pervasive it's part of your everyday?
I think before I answer that last part of that question about the unhealthy part of anxiety, I just wanted to go back a step. So in terms of healthy anxiety, it's not just the fact that we will experience it if we're living an active and meaningful life. It's the other point to make about healthy anxiety is it's not just healthy, it's helpful. A certain level of anxiety, depending on the task that we're undertaking, is helpful to us. A certain boost in our adrenaline will add to our performance or enhance our performance in certain situations. For example, if you're a student, and obviously my area of specialty is child and adolescent clinical psychology. So if I think about any of the, my own kids or kids I work with, if they were sitting an exam, then I would expect that they would experience some anxiety in light of the fact that they are under pressure to perform in that situation. And a little bit of anxiety is going to help them perform better in that situation than if they kind of cruise on into it with feeling no anxiety at all.
Right.
To answer your question, though, the latter part of your question, to come back to the main point, when someone tips over from healthy to unhealthy anxiety, the difference is a few things. One factor in terms of difference is that the anxiety is experienced on a much more regular basis, so a daily basis. The other is the degree or the intensity of the experience of anxiety. So someone who has unhealthy anxiety, or really what we're calling an anxiety disorder, is someone who experiences anxiety on a daily basis to the point where it causes them such distress and discomfort that it really impacts their daily functioning. They can't complete day-to-day living tasks. It impacts on their social skills and their ability to form relationships with others. It impacts on their thoughts. It's constantly pervading the way they think and behave.
So
it overtakes their life.
Right, I understand. So then if I was to observe that in a person, and we took from waking up in the morning and getting out of bed,
Yes.
and the typical, functions that a person goes through of a morning, having breakfast, cleaning their teeth, getting dressed, maybe having a shower, and then going out to work or school or whatever it is for that person. What of those, in those different activities we do in the morning, would you potentially see anxious behaviour or anxious habits?
So anxiety, when it's an anxiety problem, affects us in three main ways.
Right.
So it affects us physiologically, it affects our thinking, and it affects our behaviour in terms of avoidance of whatever it is that we are fearful of.
So physiologically,
thinking, or our cognitions,
right,
and our behaviour through avoidance. And the physiological symptoms are the classic symptoms that we think of, like sweaty palms, racing heart, feeling nauseous, needing to go to the toilet, or feeling like you need to go to the toilet much more. So they're physiological symptoms. So someone could have an anxiety problem and go through that morning routine being completely overwhelmed by their thoughts and experiencing all of those physiological symptoms without necessarily noticing something different about the way they're conducting that morning routine. So you may not necessarily see it in their behaviour, but they might be very worried, and that might disrupt their concentration. It might make them feel very distressed, even though they're completing those sorts of tasks. Right. It also depends on what the focus of their anxiety is. So there are 6 main types of anxiety disorders. There is, for children, separation anxiety. Mm-hmm. And then there's social anxiety disorder, so fear of performing in front of other people because of worries about being negatively evaluated or embarrassing oneself. There's generalised anxiety disorder, so having lots of worries about all aspects of life, from health to career to finances to family well-being. And then there's also specific phobias, so people who are worried about particular objects or particular situations. Classic examples might be, again, in my field, children, adolescents. It might be children who are really fearful of dogs or spiders or getting needles or things like that. Right. So depending on what the source of anxiety is, it will determine how that person will act and what they'll avoid. Right. So they may, really avoid and go to great degrees to keep away from the object of their fear. If it was someone who was afraid of dogs, they may, never go to the park, for example, because they may be worried about seeing a dog there. And if they have a real problem in terms of anxiety and anxiety disorder, that can be really difficult and interfere with their functioning in terms of socialising. If you're talking about a child and they can't see their friends at the park because there might be a dog there, so there's no opportunity to socialise outside the home because they're worried about encountering a dog, and that's certainly the case for some of the clients that I've seen, that really impacts on their day-to-day functioning. So they might be able to brush their teeth in the morning, but when they get out the door, there might be something that comes up for them then that really disrupts their routine or their life. Equally, if someone has a generalised anxiety disorder, it may be that they can complete tasks of daily living, as I mentioned earlier, but they're so overwhelmed and overrun by the constant ruminations and going over and over and over again in their mind, all the different things that they're worrying about, this sort of what-if thinking style that someone with generalised anxiety disorder has. What if my health starts to fail? What if I, can't meet, if you're an adult, certain finance repayments? If it's a child, it might be, what if my grades in 10 years' time are not good enough that I can get into university? I mean, really future-based.
Right, so not like necessarily what if I walk out the door and get, miss the bus and everyone laughs at me.
It might be that as well. But
then it could be they're
often very much orientated to future events that are quite unlikely to occur, but they elevate or believe that the likelihood of those situations is quite high, and that the damage or the cost from those situations to themselves is also quite high.
Have you seen in children, particularly older children, yes, or any, where there is anxiety over the raising or the well-being of the younger siblings?
Yes, absolutely. And it depends, I think, on things like birth order. So if the child is the eldest, for example, as opposed to if they're, the middle child and they're still younger siblings. Right. And it, again, depends on the household that they live in. We know that children who are anxious, one of the causal factors of anxiety is an anxious style of parenting. So if parents are, for example, very authoritarian in their approach, put a lot of pressure on their children, particularly older children. The firstborn usually is the recipient of a lot of extra parental pressure, lots of hopes and wishes for the future laden on the eldest child. Right. They may feel that burden, and they can become quite anxious, and that may play out in the way they treat younger siblings, feeling that they have to be responsible for them and manage them. Or you might just see that parenting style played out in the way they respond to their siblings, that they sort of become a third parent in the household, or a second parent if it's a single parent household. Right,
okay, excellent. So we've talked about anxiety on its own. However, what other mental health disorders is anxiety often linked with?
It's most often linked with depression, and that would make sense when we think about the fact that when you have an anxiety disorder, as I said, the characteristics are the physiological experience, the thinking part of anxiety, the what-if thinking style, and typically negative thinking style, and then the avoidant behaviour. So stepping away from feared situations and keeping away from feared situations. So you can imagine if that's impacting on someone's day-to-day living to the point where they, it disrupts their relationships, their well-being, their confidence, then that affects their mood. So they will lose self-esteem, they lack confidence, and that lack of confidence and drop in self-esteem is a precursor to something like depression. So most commonly, anxiety and depression go together.
Sounds like they feed each other.
They can feed each other. Not everyone who experiences anxiety will go on to also develop what we call comorbid or co-occurring depression, but they are the two that would occur most commonly together.
Okay, excellent.
And then, of course, you can see in terms of children and adolescents, anxiety coexisting with other difficulties. So children who have learning problems, for example, or learning disabilities, may lack confidence and may be very anxious, possibly understandably, about their performance at school. But what begins as an understandable fear of performance or worry about performance in a learning environment because they have an actual learning problem can tip over into extreme and excessive, intense levels of fear about attending school, about, performing in front of peers in the classroom. And again, that can be quite debilitating and incapacitating.
Right, so if you're a parent with a child with that or with some form of disability, it's something to be acutely aware of, that the child's trepidation about going into the classroom could be linked to, they have learning disability, so of course, but actually it's the anxiety that needs to be looked at.
Yes, well, it's both in that situation.
Right.
And I can certainly think of clients in the past where, for example, they've had a reading disability or a reading disorder accompanied by severe anxiety, mostly related to their school performance and social anxiety. And we've had to try and tackle both the anxiety through psychological interventions and treatment, but also that has improved when we've been tackling their actual reading skills. So we put them onto an intensive reading program like Multilit, for example, which is a very well-regarded intensive literacy intervention program. And as they've improved in that program, their anxiety has reduced as well, along with learning some coping strategies and confidence boosting strategies to manage their fears and particularly the physiological symptoms that they've experienced of anxiety. The other disorder that can co-occur with anxiety for children and adolescents, since that's my focus, is the developmental or the neurodevelopmental disorders, things like autism spectrum disorder. And we know in the scientific literature that anxiety is 4 times more common or more prevalent in that population of children versus any other clinical group or any other group of children that have another type of mental health difficulty, and certainly 4 times more common than typically developing or normally developing children, if you want to put it that way.
Right. So if we took for the moment, because we can answer this, you could answer this for both. If we looked at a person that was typical, normally functioning, let's say an adolescent, let's just pick an adolescent that's normally functioning, who doesn't treat their anxiety, what happens, or what can happen? And then if you look at a person, a teenager, again, that has anxiety, and they don't treat their anxiety, what happens with them? Okay, so if you want to start with the normally functioning adolescent or the autistic adolescent, I'll leave to you.
So for a non-autistic adolescent, so a typically developing, or we might use one of the words that's used is neurotypical. Neurotypical adolescent. Coaching you up on. Is there
any neurotypical adolescents? I don't think I was a neurotypical adolescent.
Our children are yet to reach that stage in life, so we can reserve our comments for later. Maybe no.
Okay.
But but if we think about a neurotypical adolescent, then who has an anxiety problem or an anxiety disorder,
and they ignore
if it's not treated, then we know really by the time someone is an adolescent, I think the step before that, in terms of an important comment to make, is it's unlikely or uncommon that adolescence is the first time when the anxiety occurs, sort of out of the blue. Right. Usually by the time someone is an adolescent and is experiencing a significant problem with anxiety, it's, at the sort of end point or at the climax of something that has been going on for some time, so possibly since childhood. And the problem with that is obviously, old habits die hard. So if we think about the fact that anxiety has those three main characteristics, the physiological challenges, the cognitive or the thinking part, the worried thinking and ruminations, and the avoidant behaviour, then if by the time someone's a teenager and that's left untreated, you can imagine them going into, early adulthood and later adult years, that they're very entrenched behaviours at that point. And really then quite debilitating. We would see then teenagers moving into early adulthood who may be avoidant of, quite a range of situations, depending on, again, what the type of anxiety disorder is that they have. But by that stage, certainly, if someone has generalised anxiety disorder or social phobia or social anxiety disorder, they may be, as a teenager, avoiding school altogether. I've certainly treated, 15 and 16-year-old kids whose anxiety has kind of gone unchecked until that point in time. And by the time they come to me, they're no longer attending school or they're refusing school. And along with that, as we discussed, is the comorbidity or the co-occurrence of things like depression. So they won't even get out of bed or can't get out of bed in the morning. Their mood is so low. They're so overrun with fear and worry. And then taking that picture into adulthood, again, you can imagine then
I can imagine
difficult.
It's going to limit your career choices, your
Absolutely.
educational choices, whether
Yes.
you'll go take a trade, which forces you to go into a technical college, and then also in a work site or into a university, which then forces you to sit at length in lectures and tutorials and laboratories and what have you, and mix with other people. That would preclude, if you can't get out of bed, then your earning capacity and capacity to build a life and maybe a family in the future would be significantly hindered, if not outright stopped.
That's right. And then the other aspect is some adolescents will turn to, if it's not being treated, using evidence-based approaches like psychological therapy or certain types of medications that we know have a good scientific basis for use in treating anxiety.
Uh-huh.
Those adolescents may self-treat or medicate through other things like, substance abuse, for example, as a way of coping and developing their own way of managing really difficult situations. So, we might see increase in things like alcohol and other, drug-related use.
Right. Okay. So there could be a person listening to this in their early 20s who is like that, and the opportunity for them is to pause and think back through to teenager and maybe early pre-teenager and consider what's occurred in that period of time, and help themselves try and join the dots and explain where they're at.
Yeah, absolutely, or hopefully use this as a trigger, perhaps to seek some support, whether that's within the family initially, or certainly by the time someone is an adolescent and really debilitated by anxiety, then that really is a need to get access to intensive psychological interventions and possibly what we call anxiolytic or anxiety reducing medications. And the thing about that is that's positive about that is we know they work. Right. Interventions and treatments for anxiety, when the evidence-based ones like Cognitive Behaviour Therapy or CBT, and certain types of medication like we call them SSRIs, those have been shown in literature over and over again to be very effective in treating anxiety. So it's, never too late to access support. It's harder when behaviours are more entrenched, but certainly the components or the aspects of CBT-based intervention, like graded exposure therapy, which is essentially helping someone face their fears in small incremental steps with support of a clinician, a clinical psychologist, to work through those steps one increment at a time.
Can you give an example
Absolutely.
of that?
So if we think of, again, the adolescent, as an example, I can think about even adult clients that I've treated. I'll give you an example of a really simple example of a client that I treated who was phobic of spiders. And that had been going on since she was a child. And by the time she came for treatment as an adult, she was really debilitated by her fear of spiders, to the point where she wouldn't socialise. So because she was worried about leaving the house and going to the car, and literally the trip from her door to the car and the possibility that a spider might fall down from a tree or be on her car somewhere. She had difficulty then getting to work for the same reasons. She never, dated or because she was worried about the possibility that she would be on a date with another person and engage with or see a spider and not be able to cope in that situation.
And embarrass herself, and then therefore
absolutely
didn't want that to happen in front of a would-be partner.
Exactly. So she, when she came for treatment, among other things, in a cognitive behaviour therapy sort of framework, what we did was expose her in a step-by-step manner to spiders.
Okay.
So starting at the lowest end or the easiest to manage step, which would, if you think about like a ladder, or as we talk about with kids, a step ladder approach. And the first step on the step ladder is the lowest step. So it's the one that's the easiest to manage, obviously, because it's the closest to the ground.
Right.
So using that analogy with the client, we take the step that is easiest for them to manage. The easiest first step for her was reading about spiders. So nothing to do with actually encountering a spider, but just going online and reading information about spiders. The next step was reading information about spiders and also looking at some still life pictures of spiders. Then the next step was reading information and looking at some video footage of spiders. So not still life anymore, but actually videos where they're moving. And then the next step was from there looking at images or seeing, for example, a dead spider that's been contained. And then the next step might have been a dead spider not contained, and then the next step might have been, a live spider that at a distance, etc., etc. So as the steps go on up the step ladder, they become more and more challenging. But the idea being, as you conquer each individual step, you're better able to move on to the next run of the ladder.
And at each step, you as the psychologist is discussing what with the patient? What would a patient expect to have in those discussions?
So in graded exposure
they go
therapy,
and do what you suggest,
yes,
and I go and look at the computer and I read it and I sit down in front of you, and even just talking about it to you, my palms might be sweating, I might be ready just to give up.
Yes.
In that first
Which is
instance.
exactly the case with this client, and it is with many clients who are anxious when they start off with graded exposure therapy. So for kids and for adults, the treatment approach is exactly the same in terms of principles. It's always about breaking a fear down into individual steps and tackling each step one component at a time. Literally what you're doing with that person in a therapy session is collaborating or holding their hand, not physically holding hands, but being there alongside them as they face that fear and kind of coaching them through, having already taught them in therapy other skills to use to manage. So other coping strategies like how to use controlled breathing and relaxation skills. So that addresses the physiological symptoms that they may experience when they're facing a fear.
Okay.
And then the cognitive component of cognitive behaviour therapy is all about tackling and addressing the negative, unrealistic, often irrational, black and white thinking style of someone who's anxious. So working very hard in therapy before we expose them to things that they're fearful of on giving them alternative ways to think about these situations, more realistic ways, challenging their fears by getting them to really test how likely they are. Look at things like, well, how often have you really encountered a spider from the walk from the house to the car? How likely is it then to happen this time around? What's happened to other people that when they walk from their house to the car? So keeping things in perspective.
So you give them all those tools.
Yes. And then you use those tools in the graded exposure session, where they're thinking about, maybe for children, we might actually give them a list of helpful thoughts or more realistic thoughts to challenge their anxious thoughts or their worries. And we might get them to read those thoughts and use their deep breathing or their controlled breathing skills and techniques whilst they face the feared situation. And we get them to stay in that situation for as long as it takes for their anxiety levels to drop. And we rate their anxiety. We get them to rate their anxiety using what we call a SUDS rating, which is a subjective units of distress score, which is basically a rating out of 10, where 10 is the most fearful you could experience, and 0 is nothing.
Right.
And we're looking for that rating to come down.
And that's over each.
That's within the
session, and then over.
And
sessions.
then over time. So we get them to, that would be in a session, but obviously, like any skill you learn, you can't just rock up one week and and the next week and expect that there'll be huge changes if you're not practicing those skills outside of a session. So the biggest shift in someone with something like cognitive behaviour therapy, and really any psychological intervention, is the practice tasks that people do when they're at home, and the need for them to do that on a daily basis, often multiple times a day, to keep practicing that. In the case of the spider phobic, it was, let's say we were at step 1, so she's reading about spiders. Well, every day at home, maybe twice a day or 3 times a day, she might have to get out that book on spiders and keep reading it.
So parents with children with anxiety, part of their big role in this is they can't, obviously, as you said, literally hold their hand and keep putting their arms around them and saying everything's okay. What they have to do is ensure, like doing the child's spelling or their maths or their reading, that they're doing this homework as well each and every day, and making sure that that space is available for them to do it, and that they're following through and not being mollycoddled during the process. So they genuinely feel the anxiety, and then they have to genuinely use the tools that you're giving them to bring that anxiety down and control it, and then mark themselves on a daily basis.
Absolutely. And it is, it's hand-holding in a different way.
Right, you're making sure they do it to get better.
Exactly right. So you're working alongside them, you're partnering up with them, you're forming a team with them in order to support them through the experience, rather than find a way around the experience or avoiding the experience. So you're, trying to encourage them strongly to use the strategies that they're learning in a therapy session, and practice them, yes, at home on a daily basis with the support and, in a way, the hand-holding of a parent through that. With kids, we use reward systems. So for every time a child faces their fear at home, there would be some sort of reward that's in proportion to the degree of difficulty of what they've faced. So if their ladder, for a child is, let's talk about a child who's fearful of talking in front of others, who has a social anxiety, then, when they're working on a step in their ladder, which is preparing to give news, to the class, and maybe they're on a step where they're just practicing news at home with their family, every time they practice that news, they might be rewarded with something like, getting to choose what's for dinner the next night, or maybe there's a sticker chart that's being used, or maybe they get dessert the next day or something like that. So the reward's in proportion to the degree of what they're doing. It's not that they're getting a trip to Disneyland simply for practicing news at home.
So of all the things we've discussed about the anxiety and treatment and behaviour, as it occurs in a neurotypical teenager?
That's right. You were asking about someone with autism.
Autism. So now we're looking at in that world. So what's different, or what needs to be considered in addition to these matters? And maybe a lot is the same. So illuminate me on that.
Yeah. So to be honest, not much is different. And we know that now because we've run research research that I was certainly involved in with my supervisor when I did my clinical doctorate at Macquarie University, and subsequently in writing the Cool Kids Autism program, which I can talk about later.
Yes.
With colleagues at Macquarie University, we know through those programs they're again cognitive behaviour therapy based programs, so they still tackle those same key features of anxiety in kids with autism. They were designed deliberately to use with kids with autism to address the physiological symptoms through teaching them controlled breathing and relaxation skills, the worried thinking parts of anxiety by teaching them more realistic ways to think about things that they're anxious over, and the behavioural part, the avoidance part of anxiety, by teaching them how to face their fears in a graded or a step-by-step manner. The main differences really relate more to the fact that individuals with an autism spectrum disorder have a slightly different thinking or learning style to those who don't have an autism spectrum disorder. They tend to be more visual learners. They can be more concrete in their thinking style. They're generally even more black and white. So for those individuals, what we did when we designed something like the Cool Kids Autism program was we made the resources more visual. We used more, scaffolding, more of like a recipe style approach. Step 1, do this. Step 2, do this. Step 3, do this. So it was much clearer, I suppose, for them that they had to follow a procedure each time. So making it clearer, more proceduralized, more visual, simply to tap into their learning style, as opposed to the content in terms of therapy being markedly different. And that's a good thing, because we know that, as I said, CBT or cognitive behaviour therapy used with non-autistic individuals is, as a psychological intervention, I'm talking about now, not the pharmacological side of things, not the drug or the medicine side of things,
right,
is really the most effective way. It's been shown time and time again as a psychological intervention to treat anxiety in non-autistic individuals. So it's great that we can simply adapt the same principles to individuals with autism, and that we can also find that that's effective for them as well, particularly given how prevalent anxiety is in those individuals.
So when you would consider that in your treatment, is it that, I guess it's going to depend on each child, but sometimes do you have to treat what's more often, do you have to treat the anxiety first in some way before you can really help the child with their autism and developing that? Or I guess it depends on their maturity levels and when you get to do that intervention.
Yeah, look, I think that's a really great question. The thing about autism spectrum disorder is, there's a saying, when you've seen one child with autism, you've seen one child with autism. Every individual with an autism spectrum disorder, actually, although there's we define individuals on the autism spectrum using a set of diagnostic criteria around their social and communication skills and what we call repetitive behaviours. Despite that, their presentation really varies from person to person. The way they develop is different. Development affects autism. So, some children who, when they're 3 and have autism spectrum disorder or ASD, and maybe, repetitively lining up, the classic example is sort of lining up cars or over and over again. When they're 10, that they may have a very strong interest instead in a certain genre of film, for example, that may be all-encompassing and obsessive and intense. But the fact that they've developed and have grown and matured obviously has impacted the content or the nature of their interest in the way they present.
So autism isn't just this, you're on one trajectory.
That's exactly right.
So you're on an evolving trajectory, and your autism, if I'm right, is as unique as you are as a person.
That's true. Although yes, that is true, actually. Although we know that regardless, even as individuals develop, their development is still impacted by the fact that they do have autism. So they have these fundamental difficulties with social communication, the social aspects of communication. And as we're talking about it, I'm thinking this is a great topic for another podcast episode. But to come back to your question in terms of, the way that then is, in anxiety and the treatment of individuals with autism with anxiety, because they do differ, really the anxiety treatment is not about treating their autism first, because they are so different, and really there's not a pill or a treatment for autism. It's more about looking at each individual who has autism and looking at what their particular profile of strengths and weaknesses is, and that will change from person to person. So when you're addressing the fact that they have autism, for some individuals the relative weakness might be that they struggle more socially. For others, it may be that they have, particularly there's an argument for girls on the autism spectrum, that they've learnt some coping strategies to manage better with some of the social aspects of their communication, particularly non-verbal communication, like the use of gestures and facial expressions and things like that. So they might be able to get through with those socially to some degree, still with great degree of difficulty, but to survive. And so it really differs from person to person. But we wouldn't kind of say, well, look, your child has autism, so here, do this. There's not a list of sort of go-to things that someone should do just because their child has autism, particularly if we're talking about teenagers. When we're talking about young children, then absolutely we know that there are certain types of early intervention programs that are better than others for them to use. So coming back then to the issue of anxiety and autism, we look at the fact that, as I said, they have a certain learning style, and we try and tap into that thinking and learning style when we're managing anxiety in someone with ASD. One other thing that I didn't mention is individuals with autism spectrum disorder and anxiety. We know from the literature what's coming through much more now, the scientific literature that is that they tend to have this intolerance for uncertainty. So basically a difficulty with, where they're not clear what's going to happen next. And that is a source of anxiety for them, which may be a unique feature for an individual with autism versus other non-autistic individuals who also have anxiety. So when we're looking at treatment, it would be important to factor that in to our treatment for someone with autism and anxiety, that we address that aspect if that is present for them, looking at things like dealing and coping with change, deliberately creating change and uncertainty in their environment, and teaching them ways to manage and face that and get through that we may not necessarily have to do with individuals who are not autistic but still anxious.
Okay, I'm going to pivot for a minute, and then as we look at the diagnosis piece, and then we're going to move into treatment and talk about the Cool Kids program in some more detail.
Sure.
What I want to look at is around how does someone get anxiety, so that that can be understood then in the context of when we move into treatment. So not that I want to put any parent guilt out there, but is anxiety genetic, a learned behaviour, or can it be a combination of both?
There's definitely sort of multiple factors, and when we look at what causes anxiety. So the scientific literature tells us that most likely about 40% of anxiety can be explained genetically, and then the other 60% is really from a number of other factors. So things like biological factors, so the parts of the brain that are more stimulated when someone is anxious. Different parts of the brain have been implicated in different studies. The amygdala, which is right in, deep in the brain, is a center for, processing fear and emotions. That may be sort of overly active in someone who is anxious. And then there are other scientific studies that talk about kind of a fear network within the brain. Again, different parts of the brain like the hypothalamus, the pituitary gland, the amygdala, that maybe have a sort of a network relationship. And again, and that kind of being overstimulated or overly responsive to threat-based stimuli. So that's another factor, the sort of biological side.
Right, so the brain gets together and gangs up on you too.
Yeah, well, I mean, there are some scientific papers that look at that kind of talk about the cognitive brain or the thinking part of the brain and the emotional brain,
right?
And suggesting that in a non-anxious individual, those two kind of work in sync, they balance. Whereas in someone who has anxiety, those parts of the brain that are, I suppose, part of that fear network are kind of overplay or louder, and so it's harder for the frontal lobes and the sort of prefrontal cortex, the parts of the brain that are to do with synthesizing information and planning and analysis, and making sense of emotions. They kind of speak louder, if you like. And so, yes, there is that sense of there being, the brain split into two, and for individuals who are anxious, that they have that the emotional brain, if you like, is more in control.
It sounds like tribal warfare.
So there's that. That's one factor. We've mentioned already the genetic component. Then there are other factors related to causation, like you talked about, not wanting parents to feel guilty, but certainly we know that style of parenting, and we touched on this earlier, can play a role in anxiety.
Okay. So what style of parenting is going to lead to, not always, but has a higher chance of leading to an anxious child?
Okay. Definitely a parenting style where parents are overprotective, or quite authoritarian in their approach, can be a vulnerability factor or a predisposing factor for anxiety in kids and adolescents, certainly in kids. Parents who themselves run anxious and therefore model anxiety or worry, and are sort of sensitive to fear and show poor coping, then they are parents where the children will pick up on that modelling.
So if I have a phobia to spiders, then it's likely that I could transfer that same phobia to my children through my behaviour of maybe
if you're constantly avoiding spiders,
or spraying fly spray everywhere,
for example, and articulating fears about spiders and checking the house constantly for that the first sign of a spider, then children would be observing that and picking up on that. Not necessarily that would transfer to them as a phobia of spiders. It's more about the general style of coping that children pick up on.
So
the need to be checking for things and showing lack of resourcefulness and lack of resilience, and transferring that or modelling that for children, and children learning that is the right way to cope, when obviously it's not the best way to cope.
Okay, so you could see that, the parent has the spider phobia and the child can't cope so well when their maths homework comes home.
For example,
okay.
if they're learning that one way to cope in light of fear or threats is to be avoidant and to crumble or to worry and become distressed, then in the child's own world where things come up that they are fearful of or potentially threatening, they may have learned that that's the way to cope in that situation.
Okay.
So, parenting is another aspect. And then there's just, other factors like temperament. Some children, just have a more sensitive style or personality, if you like. So that can be a factor. And then there are just other environmental stresses. We know that children who've experienced, loss, whether it's loss of a parent or who've lived through, parental separation and divorce, certainly children who've lived in any kind of adversity, whether there's been neglect or abuse, they're all groups of kids that can be particularly vulnerable to experiencing a mental health difficulty, including anxiety.
Okay, right. So for parents and caregivers out there right now who might be suddenly looking at their children or the children they look after, maybe it's grandparents listening, uncles, aunts, so on and so forth, we don't want to then end up creating my child did this and suddenly rush out the door and get them tested for anxiety disorder.
No.
So to help, and obviously this isn't direct clinical advice, what are the telltale signs that a child's anxiety is now moving from what we discussed at the top of the program, normal, and occurs under those typical circumstances where we'd expect it to occur, to it actually developing now into an anxiety disorder. So what would they be looking for?
So the main signs are that the frequency of the experience of anxiety, so it's becoming much more frequent. As I said earlier, on a daily basis, you would see the child is becoming anxious and or distressed when they're facing the situation that they're fearful of. It's the tendency for the child to, again, sort of articulate fears where they're overestimating how likely their feared event is to actually occur, even when that event may be quite neutral or ambiguous even. So using the example of the dog phobia earlier, that they fundamentally articulate beliefs that they are going to see a dog when they leave the house to walk to the bus stop, even though the possibility of that may be potentially low. It's the tendency for children to overestimate how bad that would be if they did see a dog, for example. So they talk about
dramatising it.
Yeah, catastrophising is probably the word that we would use. That they think really it's kind of end of the world stuff. It's really terrible for them if that were to happen. The other thing is just that the anxiety is really out of sync or incongruent with what the fear is. So, for example, a child who has to give news, in school, who has a social anxiety problem, moving from a healthy anxiety where they feel a little bit nervous about giving news, to the class, to a child who has an anxiety problem where they are ruminating on a daily basis, in the weeks leading up to or even the week leading up to the news, because they fundamentally believe that they are absolutely going to make a mistake, embarrass themselves, that the class will laugh at them, and the thought of that causes significant distress.
Right.
Are the sorts of signs of when anxiety is tipping over into a problem. So it's about the frequency, the intensity, the type of thinking, and the fact that thinking is really far beyond what the situation really requires. It's really incongruent with the situation. The situation sounds quite neutral to any other person, but for that individual, it's seen as very threatening and harmful. And then the other factor is just as we were saying earlier, the degree to which they're avoiding that situation is another telltale sign. That they are deliberately putting themselves out of the possibility of facing a fear. Like, if they're refusing to go to school on the day when it's news, then that starts to impact on their day-to-day functioning.
They suddenly get a stomach bug and they don't feel well.
For example. Yeah.
Okay. Right. So the two words that parents would be wanting to keep in mind if they're seeing behaviour that's catastrophising and behaviour that's avoiding given situation or situations, whatever they may be.
Yes.
And it's more than just, well, I don't want to do whatever, I just don't want to, and then you have to push them a little and then they'll do it. It's actually more extreme than that.
It's about the degree of the extreme response. So it's the intensity and it's the frequency of that behaviour occurring. For someone who is not experiencing anxiety as a problem, that response will be far less frequent. So we're really talking about, on a daily basis, quite extreme, intense responses, distress, etc. And again, it's about, we sort of think about the difference between the appropriateness of the response in terms of the content. So, it's appropriate for a 3-year-old to be, potentially fearful of separating from their parents when they go to preschool. but it's less appropriate, really inappropriate for an 8-year-old to be experiencing that same degree of distress when they're, kissing their parents goodbye and attending grade 2. So we look at that as well.
Okay, excellent. Okay, so moving now into the treatment aspect for autism, and we mentioned the Cool Kids program earlier, and you authored the autism version of the Cool Kids program, an anxiety treatment program for children in conjunction with Macquarie University. Can you give us a brief overview of the Cool Kids program?
So the Cool Kids program is a world-renowned cognitive behaviour therapy-based intervention program that was manualised, so basically put into a guide for therapists to use with anxious kids and subsequently anxious adolescents and their families. So it essentially made CBT, cognitive behaviour therapy, into a format that families and kids with the guide of a therapist could understand. It translated those skills or brought those skills to life. We talked about, challenging unrealistic fears and using graded exposure or stepladder approaches. So what the Cool Kids program did was essentially capture those approaches to treatment and put them into a program that was very user-friendly for kids and their parents. So that is now, a world-regarded, world-renowned program. And it was developed at Macquarie University by Professor Ron Rapie and colleagues there, and has now been sort of disseminated across the globe and translated into other languages, and extensions from that program have been developed for adolescents and different types of anxiety disorders, etc. So that was the original. It's had a phenomenal impact worldwide, and I'm really proud as an Australian to say that is something that's come from Australian academics and researchers and clinicians. It's a highly regarded program and one of the first of its kind. And then what we did, so that's the Cool Kids program in the original.
I think we should be proud of it. I mean, as Australians in Australia, where sometimes that people do wonder, what are we making anymore here and what are we doing anymore here? To understand better that there is a program that is being developed in this country that's now positively impacting the lives of children, adolescents and families around the world should be a sense of pride for all of us. And I can understand it's a personal sense of pride, but that more broadly is something quite significant.
So that was the Cool Kids original program was nothing that I can claim credit for.
Yeah, of course.
But what I did with as a part of my doctoral thesis, my clinical doctorate, I was very lucky to be supervised by Professor Ron Rapie, who is really one of the foremost figures in terms of anxiety research in the world. So he and another colleague, Heidi Leinham, and myself, in conjunction with Aspect, which is Autism Spectrum Australia, where I at the time was working, we developed the autism spectrum disorder version of the Cool Kids program. And we did that because, as I said earlier, we know that children with autism are, the rates of anxiety are much higher, prevalence rates are much higher in kids with autism spectrum disorder than they are in non-autistic individuals. So we were trying to see if we could adapt that program for kids on the autism spectrum and still provide the same benefits in terms of treatment that we know exist for individuals who are anxious when we use a CBT-based approach.
Okay, and so while you were writing this program, did you have any aha moments, so to speak, or eureka moments that made you rethink or better inform your approach to teaching, treating rather, children with anxiety?
I think there were probably two things I would say about that. The first, not so much an aha moment as opposed to a sort of a moment of confirmation of, science is about testing hypotheses. So what our view was that these kids with ASD, we were testing the hypotheses that we'd be able to apply what is kind of a mainstream CBT-based program to this special population. And it was our hope and our view that we would be able to do that they would have the thinking abilities and the ability to work through the cognitive challenging aspects, or the changing unhelpful and unrealistic thoughts into helpful and more realistic thoughts, which can be quite challenging even for an adult who's not autistic, let alone a child who is autistic. So we were of the view that we would see success in doing that, and that we would be able to use things like graded exposure hierarchies and stepladder approaches with these kids and get positive outcomes in terms of reduction in their anxiety. So one of the great things about that experience and running that research, which underpinned the Cool Kids ASD version,
Right.
Was seeing that was the case, that those results rang true. And then I think the second aspect was what we know again in the sort of mainstream scientific literature for kids who are anxious and their families, is the importance of families being involved in the child's therapy. So parents having a role in treatment and parents attending treatment with their kids when we're treating anxiety disorders. So, not dropping a child off for therapy and picking them up and getting the child, expecting that the locus of responsibility is on the child to manage their disorder. But parents playing a part in things like creating the step ladders and managing the graded exposure hierarchies at home and supporting the child through that. So really involving them very actively in that process, educating parents about anxiety, giving parents skills to even manage their own anxiety, because as we said earlier in this podcast, we know that there's a role in terms of modelling parental the way parents model coping or lack of coping and the impact that has on anxious kids. So what we saw again in the ASD version of the Cool Kids program when we developed it and ran it through my doctoral research was that again there was that benefit. It really made a big difference, a significant difference, to have parents involved in that process, to get them to come along to the treatment sessions and to have separate education sections for the parents, separate to the kids, while the kids were going through their own therapy or coping strategies and learning those strategies, but also moments in sessions where they were working together as a family unit and setting up hierarchies and homework practice tasks, and then coming back the following week and looking at how they'd gone with those and adjusting from there. So it was just as beneficial to have parents involved with those kids on the autism spectrum as it was and as we saw in other research.
Okay, excellent. So what if a person or a parent wants to address the anxiety that they see in their child, or what would be the first step or best first step that they should take? Is it go access the Cool Kids program directly, or do you need to go speak to your GP first and then you can go into that type of program? What are your recommendations?
Well, I think it depends again on this idea of the balance between healthy and unhealthy anxiety. There is certainly skills that parents can develop and work on in terms of modelling confidence for kids who have healthy anxiety but just need to be perhaps a little bit more resilient. So things like boosting children's confidence, having a can-do attitude, supporting children to face fears more generally rather than avoid them. Those are general things that parents can do. But
so talking about where they've had to face a fear during their workday, when they come home, to help the child understand that it's a normal part of life. You have to do it as an adult as much as you have to do it as a child.
Absolutely. Yep.
Okay.
Or yes, that's a really good example actually. So modelling that in terms of how they've faced their own day, but also talking through with their child. Okay, I can see that this is something that you're fearful of. Let's problem solve some ways that we might face that fear. And the child might say, well, I don't want to. For example, let's say it's a separation worry. I don't want mum or dad to go out tonight. I want you to stay home with me. So as a parent trying to problem solve with a child ways that they could cope by making it clear that, in fact, mum and dad are going out tonight. So let's think about what you could do knowing that we're going out. One thing that the child's coming up with is, well, just don't go. Yes, okay, well, yes, that's one possibility. So validating what the child is saying and saying, yes, okay, well, we'll accept that for now. We'll talk about that as well. But what other ways could we problem solve this situation? Is it that we could, maybe have someone that you can call if you're feeling nervous? You've got obviously the babysitter here. You can talk to them about it. Maybe you could put a movie on that will take your mind off it, those sorts of things. So having a can-do approach, an approach where, you're ultimately going to come to a point where you say, look, we are going to go, but you've got some strategies to manage in this situation. You will be able to cope. You've coped before. Nothing terrible is going to come of this, and we're all going to manage and get through it. So we're really boosting resilience and confidence and encouraging kids to work through that. That's something that parents can do more generally with children, at any time, whether they have healthy or unhealthy anxiety, and mostly when they have healthy anxiety. When a child has unhealthy anxiety, when a child has an anxiety disorder, then really we know that treatment, as we've discussed, is really required. Some children do, can recover from that with intensive parental support. But more often than not, children are better placed by accessing some sort of psychological intervention. And so the process to get to that, or the way to go about the pathway to that, these days with things like Medicare rebates for mental health support, etc., is, yes, the first protocol might be the GP in order to look at whether the child, does seem to present with an anxiety difficulty, and then the GP referring them to a clinical psychologist, for example.
Can you go direct to the clinical psychologist?
Yes, definitely. Parents can go direct to the clinical psychologist to try and start off supporting, and using a CBT-based approach, and that really is the expertise of a clinical psychologist. The other thing is, or sometimes psychiatrists might be involved. Sometimes the GP and the clinical psychologist work together, or the psychiatrist and the clinical psychologist work together if the anxiety is so severe that it needs a combination of treatments like medication and other psychological strategies. And usually, the role of medication is to reduce very, very severe anxiety to a point where the child or the adolescent is able to function in a therapeutic intervention. So it allows them to then be in a position where they can start to help themselves.
So just to help define that there, am I right in saying that the psychiatrist is the only one of the psychiatrist and clinical psychologist? The psychiatrist is the only one that can prescribe the medication.
Absolutely.
Your clinical psychologist cannot.
That's
that's why they have to work together in that very specific scenario where the patient has to have medical intervention before they can really get value and benefit from the therapeutic intervention. That the clinical psychologist, that's where their expertise lies.
Yes.
Okay.
And sadly, that doesn't always happen. In fact, frequently that doesn't happen. They don't necessarily work together. Like many aspects of our health system, it can be quite disjointed, and families can, kind of sort of doctor shop and clinician shop, trying to find the next person that will give them, sort of instant results. And usually that's out of desperation and concern, because by the time you're looking at medication to treat anxiety, the anxiety is quite severe and debilitating.
So
but
for those
it is
parents,
important that they do.
The rock solid advice for them, because they are obviously under a lot of stress, and I could empathise enormously with them, because you only want your loved ones to have a normal life, or as normal as possible life. That what you're looking for is a psychiatrist and a clinical psychologist that will work in lockstep to the total benefit of your loved one.
That's exactly right. And in Sydney, which is where we are, there are definitely clinics where, there are psychiatrists and clinical psychologists, for example, who work within the same practice. So then that's much more advantageous for those families.
One visit you can coordinate to go one visit,
potentially
see one and then see the other.
Exactly.
Potentially. Yeah.
Or there are places like, the Centre for Emotional Health, again, which is at Macquarie University, but it's a centre of excellence in terms of, research but also the application of that research. So it's a centre where there are, scientists and academic, professionals who are researching best practice treatment for anxiety and other aspects, the theories around anxiety, causation, all the things that we've discussed. And there's a clinic attached to that, which we mentioned Heidi Lynham and Ron Rapay earlier. So Ron is the founding director of that centre,
Okay.
and Heidi is the clinic director at the centre. So that is a centre where they have actual clinical psychologists, professionals who are fully registered and working, but they also have students who are completing their clinical psychology registration, and they're supervised by more senior clinicians. So families can access support there, and that typically, because it's in a university institution, might be with some subsidised costs from the university. So that's another potential option. And there are other university clinics, not just in Australia, but worldwide, that are teaching institutions for clinical psychologists and for psychiatry, etc., where families usually can go to a clinic within the university institution and access support there as well, and see that more connected model of care.
So families can not be overwhelmed by this, but they can literally go to the source, the university, in this case, say Macquarie, or as you said, any in the world. Don't be overwhelmed by that fact. Don't think that you're not of that level, or you have to be some special case before you go in there. That you can really cut to the chase and go see these people, and you will get potentially, in the case definitely Macquarie University, the premier or the number one healthcare for this in all of Australia.
Without a doubt. And I think the other thing to say is, sometimes families think that, or can just understandably be reactive. Typically you don't want to be taking your child off to a clinician when it seems like the child's anxiety may potentially be borderline, like sort of something sub-threshold or subclinical, not, super distressing, not causing lots of difficulty in terms of their day-to-day functioning. So they don't want to, be too alarmist and create a problem that isn't really there.
Going into their final years of high school,
for example.
And you could be like, well, I don't want to make this worse.
Yeah, by drawing attention to it, and making them...
But they're going to march you into an enormous university, you're surrounded by lots of people, and then go see someone to talk about this.
Yeah, and then make the child sort of second guess themselves and go, well, actually, maybe I really do have a problem.
Right.
But having said that, there is nothing wrong with, at any stage, learning good coping strategies. And I've certainly seen clients over the years who don't have a child, even who has an anxiety problem, but maybe has a child that has could be vulnerable or have that sort of temperament. Or tendencies that we talked about.
Yes.
And want to simply learn good strategies and approaches to help their child proactively to manage anxiety.
It's interesting. It's interesting you say that, because typically what you kind of think about is that if you're struggling in maths or history or English or whatever, then you go see a tutor, right? So you go see a tutor to improve. Maybe that isn't the case for your child. Maybe they don't, maybe seeing the tutor is important, but maybe seeing, as you said, someone that's going to also tutor you or help you with the coping mechanisms to bring those anxiety levels down, get in greater control, well, you're going to begin absorbing more in the classroom and learning more. And then maybe, yes, you need tutoring. That's completely fine. That's up to you. But that could actually be, well, go treat that before you then kind of load up more on the extra curricular training, for example.
That's correct. And then so coming back to your question about treatment options, that brings me to another point, and that is that there are lots of great books and resources out there for families who don't necessarily need to or feel ready to directly access treatment in a clinic or with a therapist, whether they're in an institution like a university or whether they're a private practicing, clinical psychologist or psychiatrist or therapist. There are self-help guides, if you like, for parents to work with and support kids who have a tendency to be anxious. And again, I suppose to highlight the work of Ron and hiding in their colleagues. But that is because they really are leaders in this field. There is a book called Helping Your Anxious Child, and that is a guide for parents, or a book that parents can purchase, on Amazon or through Booktopia, and simply read about strategies that would work at home to build confidence in kids and work through, situations that children fear, and just to help level off, tendencies to be anxious.
Okay, we've got some other resources that we want to mention. Before we do that, just quite specifically, if you're there could be teenagers listening to this, and that they observe in their friends at high school. It could be young adults that they're observing in friends that they've made at university, and they're concerned about that person's level of anxiety. What are some ways that you could give to young adults some ideas of how they could approach their peer to discuss their anxiety, and to maybe encourage them to think about it, if not go get treatment? That's not going to then result in maybe a breakdown in that friendship, or cause more anxiety, which the friend wouldn't want to see. So how could be a way, some tips that they could approach that friend as to that what's going to help improve the situation, not make it worse?
Look, I mean, my own, it's a really excellent question, because for me personally, I can think of an interaction I had with one of my own patients who is a teenager in therapy recently, and she said to me what she wanted from her friends were people who were supporters, not enablers. And what she meant by that was she wanted people to support her in trying to learn to cope with things that made her anxious by encouraging her, and again having that kind of can-do approach for her. You've got this. I know you can manage it. Give it a go. Those sorts of things.
Okay.
As opposed to enabling her to avoid the things that made her anxious, and giving her encouragement around showing lack of confidence. So, more broadly speaking, I suppose giving attention and praise and encouragement to brave behaviour in their friends would be something that they could do, just as parents could do that for their kids. Certainly adolescents can do that for other adolescents to be supportive, rather than helping a friend avoid something that makes them anxious, because really that's the worst thing that you can do.
So if they've got a friend who doesn't really like coming out, don't invite them to a party where there's going to be 60 people. Maybe go to their place for a coffee, or have them to your place for a coffee one-on-one, and then praise that behaviour.
It could be absolutely that, yeah.
Then,
or if they can get to the party, maybe only stay for the first 5 or 10 minutes, and then plan to go off somewhere afterwards to sort of celebrate that small win with like a coffee or a movie or whatever it is.
Okay.
But I think the other thing is just to let the friend know that that it's normal. That it is okay to have these experiences. Sometimes adolescents feel like they're the only ones going through these emotions, and they feel, or they isolate themselves because of those worries. So trying to encourage them and explain to them that, really, we know from just the stats that really up to 20% of the population will experience an anxiety problem at some point. And for 3 to 17-year-olds, that's as high as, 10%. So, it's not as uncommon as we might think. And so taking the stigma out of it, making them feel like it is a reasonable emotion to have, and that it can be a normal experience, but maybe it's just that they are having that experience, as we said, too frequently or too intensely. So all it is a matter of just getting some help to bring that back, and putting it into some perspective like that would be a good way, I think, that would be more palatable for a teenager, rather than feeling like they really have a big problem, and making them feel like there's a stigma or something that they should isolate themselves from others because they are, on their own in this.
Right, excellent. Okay, so let's just list those resources again. We will put links to all of the resources in our different social media posts and podcast, YouTube, etc. So let's. I'll have you step through those.
So the clinic that I was talking about, so it's the Centre for Emotional Health, and that, as I said, is at Macquarie University, which is, again, a centre for excellence in terms of scientific research around anxiety, whether that's adolescent, adult, child, parent, or, the interaction of parent and child anxiety, and a centre and a clinical centre as well, where anxiety can be treated either individually or through group programs. There's a number of resources that families can access on that website. There are articles and scientific articles and papers that not just families but other clinicians might want to read in terms of upskilling themselves and their own professional development. So, there are so many different aspects to that centre in terms of the sorts of services they can offer in managing anxiety. Beyond the Centre for Emotional Health, the Cool Kids program, which can be accessed at the Centre for Emotional Health, we talked about already.
So that's worldwide. So if you Google,
it's been translated into Spanish, Danish, Korean, all sorts of other languages as well.
So you could just Google Cool Kids. So cool as in COOL. It's not any funky spellings. Cool Kids program, and you could just Google that and see if it's offered in your area, your region.
You could see if the program's being offered, but again, you can purchase the language translation of that program at the Centre for Emotional Health. That is the centre where it was ultimately developed, or through the researchers who are now at that centre or who founded that centre. And so, yes, if people access the Centre for Emotional Health, they'll be able to access a number of products and resources, including the Cool Kids program and the languages in which it's been translated.
So, for example, just to clarify that, if I am in Korea and I am a Korean, I can go online and purchase the Korean translation and have that shipped across to me.
Correct, and you could use it as a Korean therapist with your own clients in Korean, or you could be a Korean family and look at the parent workbook of that program and work through some of the strategies with your child.
Okay, excellent.
So yes, either of those options. We mentioned Helping Your Anxious Child, which is the book that Professor Ron Rapie and colleagues wrote, and that's available through Booktopia and Amazon. I highly recommend that book for families.
Right.
And then there are fact sheets, again, that can be accessed. Again, an example is at Macquarie University. And then, of course, the book that I wrote, which relates to individuals with autism and anxiety, which is Managing Anxiety in People with Autism, a treatment guide for parents, teachers and mental health professionals. And that, again, is accessible online through Amazon.
Okay, and as we said, links to all of those resources will be on our social media and on the podcast and YouTube channel. Okay, well, fantastic. Thank you very much for an excellent session on our main topic, understanding anxiety. Now, in that frame, you've been putting a lot of posts on Facebook with different information. And one recent post on Facebook and LinkedIn was entitled Managing Anxiety in Kids and Building Confidence. So you wrote in that post, children are presenting more and more with anxiety and worries. What can parents do to help them? So, Dr. Chalfont, what can parents do to help them?
So this was coming from, as you said, a post that I'm writing for LinkedIn and Facebook almost on a daily basis. But I've taken the Thursdays each week and focused on anxiety each Thursday.
How many have there been so far?
I think there's been 4 Thursdays now. So this was the first of those Thursday anxiety posts and tips. So we're starting with the kind of lower level or easier steps, and we've been building each Thursday on this first tip. So the first tip was around building confidence, and then we've looked at a can-do attitude, and then in subsequent weeks we've talked about teaching some simple relaxation skills, and then I think the fourth one was around perspective taking, and we were talking earlier in the podcast around, trying to transform unhealthy worries and unhelpful thinking styles into more realistic perspectives and problem solving.
Okay.
So that's what that one was about. So this was the first one, and it was simply around the idea of just getting parents to shift their attention from worries to bravery. So trying to change their focus from cajoling kids or teenagers when they are feeling worried and nervous and hand holding them through that too much, to giving their attention instead to when children and adolescents are being brave, and that being a first step at building confidence, because we know that depending on where attention is given, we will see more of those behaviours. That's just simply, behavioural science at its simplest. So the more attention we give to a behaviour, the more likely we are to see that behaviour occur.
Right.
If we give more attention to brave behaviour, then children are more likely to show brave behaviour more often. And if we reward brave behaviour, then they'll be even more motivated to show that. So it was just simple tips like finding opportunities at home to encourage and praise up your child for doing something on their own, for being brave in anything, like, maybe you go out to dinner and the child is the one to order something off the menu when they normally wouldn't. So that might be worthy of praise and making a big fuss about how brave that child was in that situation, and really trying to encourage parents in that post. I was talking a lot about the specific language that they use. So it's really important to be very specific when you're praising children in order to really target exactly what the behaviour is that you want to see more of. So using words like, you were so brave, you did that on your own, you did that without my help. Those sorts of catchphrases are really critical in highlighting to the child in a really obvious way exactly what it is they're doing that is so great, and then that's what motivates them to continue with that or keep showing more of that behaviour or perpetuating that behaviour. So it was about trying to encourage bravery in kids using those catchphrases and trying to be, I suppose, like a detective and catch kids out at any simple opportunity where they are being brave, whatever that might be.
So we often catch kids out when they're doing something wrong. This is catching kids out when they're doing something right.
Yes, and then finding little opportunities maybe to deliberately create situations where a child can show independence. And in that way, we've sort of manipulated things so that we then have an opportunity to praise them for bravery. For example, maybe parents can give their kids little responsibilities or extra jobs around the house, and then use that as an opportunity to highlight back to the child how the child did that on their own, or did that without the parents' help, or did that independently, or did that really bravely. Exactly.
Okay.
Yeah.
Excellent. Right, fantastic. So it's on the Facebook page. It's at Dr. Anne Chalfont. You can search for yourself and Annie's Centre, and they can get that post and many, many others.
Yes, and as I said, that was a Thursday anxiety post, and there's been others since then that sort of build on that initial skill.
Fantastic.
All right, so I think we're up to our last segment, which is Kids in the Kitchen. So
That's
Justin,
right.
over to you.
The first recipe that I thought we would get kick off with is one that was actually found on one of those grocer's cards that you get at the local greengrocer or even at your local supermarket, and it's called roast garlic and lemon chicken. And I love this recipe specifically is because it's all basically cooked and then served in the one tray. So you can scale it up and down. You can increase the amount of ingredients if you've got more mouths to feed, or you can reduce it down for a smaller size.
And this recipe is amazing every time we make it for guests, friends, kids.
Oh, it's a great one for guests because it can be done not quite last minute, but it doesn't have, you're not spending hours and then waiting for the souffle to rise. And if the souffle doesn't rise, then you're going to be out there crying in the corner and ordering pizza.
People love this recipe.
People love it. It's pretty.
It's delicious.
Yeah, it's delicious, and it's fairly foolproof. So 6 ingredients: chicken pieces, legs and thighs, garlic, thyme, lemon, olive oil, and salt and pepper. So that's it. You can combine all of those in a large dish. You line a foil tray with baking paper and then place one layer onto that tray of all of those ingredients. You roast it in the barbecue or oven and serve it sprinkled with feta cheese straight from the tray. So drop the trays down, put the tongs on, feta cheese, and you're done. So maybe a salad on the side and a bit of mashed potato, and you're on your way. So on Facebook, we will post the pictures of the recipe card, so you can get all the details of that. The photographs of a version of it that I cooked very recently on the barbecue, and you can see that there were several trays because we were cooking for guests.
And we had no leftovers at all because everyone wanted seconds.
And it's a real shame. And when we cook with garlic with this, you might be, concerned that, you're going to be there forever crushing garlic cloves or slicing garlic into thin slivers rather of garlic. Then you don't have to worry about that. You literally take the entire garlic head and chop it in half and throw it in the dish. It's only as hard as doing that, so that's fantastic. So highly recommend that one, and details will be in the Facebook page.
And we'll have other kids in the kitchen recipes.
Absolutely, there are loads.
Fantastic. Okay, well, I think that's it for this episode of our very first podcast. Hopefully everyone has found something that they can take with them moving forward on anxiety or confidence building in their kids or their adolescents. We're always open to, in either through Facebook or other ways of contacting us, ideas for what people would like us to do podcasts on.
Yes, please.
But just to finish up with, I have a joke. I like to finish sometimes on a joke. My patients often ask me to tell them a joke in sessions.
Okay.
Not necessarily because I'm the world's best joke teller, but nonetheless they seem to keep coming back.
Okay.
So here's my joke. What did the left eye say to the right eye?
I do not know. What did the left eye say to the right eye?
Between us, there's something that smells.
Okay. Good. I like that one. Well, as we said, that's a wrap for this episode of the Annie's Centre podcast. I'm Justin Kingdon.
And I'm Dr. Anne Chalfont.
Our mission is to help families thrive, and we hope this episode has done just that. Let us know by visiting the Annie Centre Facebook page and leaving a comment. You'll find Anne on Instagram, Facebook, LinkedIn and Twitter, and search the hashtag Dr. Anne Chalfont or hashtag Annie's Centre. And that's centre spelt the English way, which is CENTRE. So at ANNIES CENTRE or at DRANNECHALFANT or hashtag Dr. Anne Chalfont or hashtag Annie Centre. And don't forget to leave a rating and a review on the podcast app where you found us, and tell your family and friends to listen and do the same.
The Annie Centre podcast was brought to you by Annie Centre Proprietary Limited. Please visit anniecentre.com and subscribe to receive the latest updates and digital downloads from Dr. Anne Chalfont.